Hi friends, I am Dr. B.V. Rao of Bushra Clinic and founder of the websites qmedicaldoubts.blogspot.com and raghavamedicaldoubts.com. Through these videos, I am providing the basic knowledge about the commonly occurring diseases, treatment and surgery details when necessary for the medical knowledge to general people and for reference to medicals. Today I am going to discuss about the congenital abnormalities of rectum and anal canal. Imperforate anus. It is present due to imperfect fusion of the post-allantoic gut with the proctodium. It is of two types, high and low, depending upon whether the termination of the bowel is above or below the pelvic floor. The low type is easy to diagnose and simple to treat, and the outlook is good. The high type often have a fistula into the urinary tract together with a deficient pelvic floor, and the prognosis is not good. Low abnormalities. The covered anus. The underlying anal canal is covered by a bar of skin with a track running forward to the perineal raphe. Treatment. The track should be opened with scissors followed by a routine dilatation of the anus. Ectopic anus. The anus is situated anteriorly and may open in the perineum in boys and commonly in vulva in girls or rarely into the vessel. Treatment. A plastic cutback operation is required. Stenosed anus. The anus is microscopic but careful examination reveals a minute opening which responds to regular dilatation. Membranous stenosis. Here the anus is normally sighted but is covered with a thin membrane which bulges with a retained meconium. It is rare. An incision will cure the condition. High abnormalities. Anorectal agenesis. A blind rectal pouch lies just above the pelvic floor. Its anterior aspect in the male is attached to the bladder, and often there is a rectovesical fistula manifested by the passage of gas or meconium in the urine. In females, the fistula is usually into the posterior cortex. Rectal atresia. The anal canal is normal but ends blindly at the level of the pelvic floor. The bowel also ends blindly above the pelvic floor without a fistulous opening. This anomaly is rare. If present, is treated by mobilization of the rectum and excision of the stricture, followed by end-to-end anastomosis of the anus and rectum is attempted. More conservative measures are followed by an intractable stricture. Cloaca. This occurs only in females. The bowel, urinary and genital tract all open into a common wide cavity. Commonly there are severe malformations of the area associated with other developmental abnormalities elsewhere. Management. A very careful general examination of the baby must be made to exclude any other anomalies. It is decided whether it is high or low. X-ray confirms the diagnosis. X-ray with a metal button or a coil strapped to the site of the anus or a metal bogey inserted into the blind anal canal. The infant is held upside down for 4 minutes and a radiograph taken in inverted position. The gas in the rectum will rise to the top and indicate the distance between the side of the metal indicator and the blind end of the rectum. If the distance is more than 1 inch, the abnormality is high. This method, though useful, is sometimes vitiated by a plug of meconium in the rectum, causing an apparent gap for in excess of that actually present. It may be necessary to wait till the baby is 24 hours old before rectal gas appears. If a high lesion is suspected, an effort must be made to obtain a specimen of urine. The presence of proteus or pyogenes usually signifies the fistula is present. An excretory radiograph is recommended by some, but there is a radiation risk. There may be gas in the bladder. Treatment: low abnormality. It is usually simple and has been outlined when each condition is described. The high abnormalities present a difficult problem, and each case must be considered on its own merits. On the whole, newborn babies stand surgery very well, provided compatible blood is available and a clear way is maintained post-operatively, and inhalation of the vomit prevented by nasogastric suction. The presence of other congenital abnormalities is also a most important factor to consider. The possibilities are laparotomy, division of rectourethral fistula, and transverse colostomy. A rectal pull-through operation can be done later. Laparotomy, division of fistula, and pull-through operation in one stage. The other is the division of fistula and rectal pull-down operation through the perineal route or sacral route, of course. These days are rarely done. Cloacal type. Colostomy. Colostomy only is performed. Pull-through operation. For pull-through operation, the lower bowel is mobilized and a new passage is created through the pelvic floor by passing a pair of curved forceps through it, keeping close to the urethra to the future anus. This is dilated by Hagar's dilators so that the bowel can be pulled down and its mucosa stitched to the skin of the newly formed anus. In general, daily dilatation for 3 months or more may be required. The imperforate anus is associated with other congenital abnormalities like urinary organs and other organs. Sacrococcygeal Teratoma. It is rare and females are more often affected than males. The tumors arise between the sacrum and the rectum, is firmly attached to the coccyx and occasionally to the last piece of the sacrum. At the time of birth, some of these tumors are huge, and in 20% of cases the infant is stillborn. In some cases it is small enough to pass unnoticed till it enlarges or a complication ensures. This type is prone to become malignant at about 10 months of age. Treatment: removal soon after birth. The delay is liable to result in fatal ulceration, infection, rectal or urinary obstruction, or a malignant change. Operation: excision is undertaken through a longitudinal elliptical incision. The coccygeal attachment is left till the last. The coccyx must always be excised occasionally. The last piece of the sacrum must also be removed. There may be a fistula between the tumor and the rectum, but as a rule this is small and can be closed safely without performing colostomy. The dead space in the pelvis is drained and skin is united and a pressure dressing applied. If this operation is performed soon after birth, the prognosis is good. Post-anal dermoid. The space in front of the lower part of the sacrum and coccyx is occupied by a soft cystic swelling, a part of anal dermoid cyst. It is regarded as a simple form of teratoma. Hidden in the hollow of the sacrum, it is unlikely to be discovered unless a sinus communication with the exterior is present or develops as a result of inflammation. Such a cyst usually remains symptomless until adult life, when it is prone to become infected. Exceptionally, by its very size, it gives rise to difficulty in defecation. The cyst is usually palpable on rectal examination. In a child, anterior sacral meningocele is to be excluded. Sacral meningocele enlarges when the child cries and associated with the paralysis of the lower limb and incontinence. Pilonidal sinus is mistaken when there is a discharging sinus present. Treatment. The treatment is the complete excision of the cyst and the sinus if present. In case of large cysts, it is necessary to remove the coccyx to gain the access. Post-anal dimple or fovea coccygia, a short blind pit in the skin beneath the tip of the coccyx, is noticed from time to time in the course of a clinical examination as a dimple. A dimple in this situation has the same significance as the dimple in other sites. It represents a local fixation of skin by collagen fibers to underlying structures. Such a dimple is a starting point of a pilonidal sinus. Pilonidal sinus. Pilonidal sinus could be connected with a post-anal dermoid or a sinus resulting from a persistent caudal remnant of the original neural canal. Occurs in sacral than coccygeal region and is definitely connected with the spinal theca. So, meningitis from an extradural abscess may occur in a child. Clinical features. There is a chronic or recurrent sinus in the midline about the level of the first piece of coccyx. A tuft of hair projects from the mouth. The discharge from the sinus is often blood-stained, contains foul sebum and sometimes hair. Symptoms usually start from the third decade. Patients present in later life nearly always give a history dating back to this period. The patients are usually hairy and obese. The condition is confined to the white races. The complaint is of discharge pain or a tender swelling at the bottom of the spine. There is a history of repeated abscess in the region that have discharged spontaneously or have been incised. The primary sinus may have one or as many as 6 openings, all of which are strictly in the midline between the level of the sacrococcygeal joint and the tip of the coccyx. Unlike a fistula in ano, the sinus passes upwards and forwards towards the sacrum. It does not reach bone but ends blindly near the bone. If an abscess forms, it is discharged through the primary sinus. Frequently it points and bursts or is incised to one side of the midline, thus forming a secondary sinus. Conservative treatment. Patient with mild symptoms can be cured by conservative measures. The conservative measures consist of frequent washing of the parts with a detergent and water and applying equal parts of which as well. That is liquid extract, hemelis and alcohol. Long sitting driving a car is avoided. These measures tried on a large scale proved tolerably successful. Treatment of exacerbation. If rest, sitch baths, local antiseptic dressings and broad spectrum antibiotics fail to bring about resolution, the abscess should be opened through a comparatively small incision. If all hair and granulation tissue are removed from the abscess cavity, there is some prospect of curing the lesion. In all other circumstances, an elective operation must be planned. Steps of operation. Operation is performed only when the inflammation is controlled by conservative measures. Procedure. The patient is placed on the operating table in jackknife position. Methylene blue is injected into the sinus to color all the tracts. The nozzle of the syringe is pressed against the opening to obtain some pressure. A director is then inserted and the cavity is laid open along its length. If diverticula are present, they are also dissected out. All hair and debris must be removed. In this way, all sinuses are exteriorized. Bleeding points are not tied but only clamped. At the end of the operation, the hemostats are removed and a piece of ribbon gauze moistened with 1:1000 adrenaline is used to pack the wound. A pressure dressing is applied. After 6 hours, the pressure dressing is removed and a gauze moistened with a saline solution is placed over the ribbon gauze. Next day, whole dressing is removed and moist dressings are continued as an outpatient. The wound is inspected twice weekly for bridging or for the presence of any sinus that has been overlooked. In 8 to 10 days, the wound should be filled with healthy granulation. By that time, a tulle gross covering is all that is necessary. The average time of complete epithelialization is about a month, but possibly this can be speeded by skin grafting. Recurrent pilonidal sinus. There are 3 causes. A diverticulum of the main channel is overlooked at the primary operation. New hair enters the skin or scalp. When the natal fold is deformed by scarring following block dissection. The least trauma causes tearing of the scar, and the resulting crevice becomes contaminated with coliform and cutaneous bacteria. That's all about the congenital defects of the rectum and anal canal. And in the next video, I will discuss about some other disease. Thank you.